Now we have Dr. Cassandra Germain, who has all kinds of titles. And so I'm going to just psychology at NC A&T State University. Um, do I call it CIDR or CHIDR, the Center? Oh, you're muted, Maya.
Exciter. I am
Yeah,
muted.
I thought CIDR, the Center for Integrative Health Disparities and Equity Research. I might say it wrong,
Yep.
the Aging and
You did.
Wellbeing
That was
Lab.
perfect. Yep. Mhm.
See, and I'm not even looking at my notes. I'm so impressed. I've been following you around.
I'm
And
impressed
so
as well.
I'm just going to turn it over to Dr. Cassandra Germain because I asked her to, I know, and then she knows I was looking at it. I was excited again to look at stuff again at 3:45 in the morning. Last night, she's done some really exciting research on health equity work and health disparities work, especially on Alzheimer's disease. But also, I know for a fact that she had a meeting recently with her students, talking about in general health equity and policy and advocacy in and so I was like, can you come on and give an update? And so I'm gonna stop talking now. And Cassandra, you do the more proper introduction for you, but I'm really excited to hear from you. Update us,
Well,
my friend.
you gave me permission to be informal, so I've planned
I
an informal
totally did.
presentation today. I have been scrambling on grant work, so I am going to just talk a little bit about what we're doing. So one of my roles, as Heather mentioned, I'm Associate Director of Training and Education for our Center for Integrative Health Disparities and Equity Research Center. And as part of that center, we work with students to really an interdisciplinary group of students in our College of Health and Human Sciences to really start learning and becoming more aware of health disparities and equities research. So regardless of their discipline, whether they're future physicians, nurses, public health folks, that they are in a position to be thinking about that and thinking about where to affect change. So last week, we had the team at Novant Health from their palliative care unit to talk a little bit more about advanced care planning, which is, not something that people like to talk about, especially in communities of color. So students had a great education about that. And what I told Heather that I'll talk about today is some recent work that my team in my lab, the Aging and Wellbeing Lab, have been doing in Guilford County, and we do plan to expand this work, hopefully in the Southeast region in the very near future. Talking a little bit more about Alzheimer's disease awareness. So, and brain health awareness as a whole. So I gave Heather lots of cheat sheets, and I know she's an excellent interviewer. So I'm going to let Heather interview me, but I'll give a little bit of background and overview about what motivated me to start this research, because all of us here, we're kind of knee deep in the aging world and the dementia world. I mean, many, if not all of us, have been caregivers of some sort. So this is both a work of passion as well impacts us personally. I lost myself. I lost my grandmother to Alzheimer's disease, and I was her caregiver for a decade. And before that, I lost my mother to breast cancer. I have an adult child who is on the spectrum. So I am like a lifelong caregiver. So I'm really passionate and interested about bringing awareness to people about things that they should be aware of. So in my kind of day-to-day work, whenever I found myself in groups of people, whether it be in casual conversation or even in settings in the community, I found people asking me a lot of questions about brain health still. And, I mean, I started recognizing or acknowledging my own, egocentrism, because I was like, well, everybody knows about Alzheimer's disease. We're talking about it all the time. You've got great work being done by Alzheimer's Association. Our state is doing great work, and we have so many organizations. But I was getting a lot of questions about risk factors. I was especially getting a lot of questions from people about early warning signs and how do they identify transitions between, normal function and, slipping into, mild cognitive impairment. And, these questions came from people from a variety of educational levels and backgrounds. So it wasn't just only people who were uneducated. I mean, I had highly educated people saying, well, my mom's having, these symptoms, what should I do? Is it normal? And so I found myself kind of, off the cuff dispelling all these aging myths and educating people about those things. So I decided about a year and a half ago, my team and I, to do kind of like a systematic snapshot of, what do people really know about and what myths are still persistent. So we conducted kind of, we did it in a fun way. We did a quick assessment about what people knew about brain health. So we included some questions about risk factors. We included some aging myths in there. So some examples of those are about chronic disease impact. So things about diabetes, heart health. We also included some questions about lifestyle factors. So things like walking and nutrition. And we also included some general things about aging. Is it normal for people to forget common words? Is it normal for people after a certain age to, get lost in familiar places? Is delirium always a sign of cognitive impairment? And our results so far have been really surprising. So we had about, correct me if I'm wrong, I think maybe about 400 people completed, and we asked people from all age demographics. And surprisingly, we found that there are still some aging myths around there. So I'm going to pause. I'm sure Heather has a burning question. I see her taking notes. So,
Oh, I'm taking all kinds of notes. And yeah, this is an informal discussion. And so if people I'll ask some questions, but then if you're so inspired, folks, feel free to either raise your hand or just throw it into the chat or just interrupt me because if I miss things and I'm on a smaller computer screen. So so you gave a little bit about the why you
mhm.
did it. I guess go into because there's just so many, it's like the who, what, why, because I really want to dive into the findings because I did get a little
Yes.
sneak peek of them. So I've seen and I'm like, wait, what? So anything else contextual that people need? So
Yes.
I think you talked about 400 folks. How did you decide like how, because, and if you can do the age range, this is like leading you on because I know it was a funky age
Yes.
range, and
Yes.
where you found folks and I think you probably put it in, but were you focused on last part of this question on sort of all races and all ages, and I know economic level and education level because I saw how you broke it down. So that's all the leading question about this sort of
Yes. So,
who
okay,
and
great.
how.
So I'm going to go into the house, and that's a great question because we did have some specifics in mind. So of course, because of we're doing some health disparities work, I was really interested in kind of because people who are motivated to engage and learn more and protect their health and engage in proactive behaviors, they're attending all the seminars, they're coming to all the health fairs. I mean, even with our institution, I mean, we collaborate frequently with Cone Health to put on a huge health fair every year, every summer. We go out, we join them also on some rural health outreach. We've been out to what county was that? Rockingham County. We've been out to the kind of the rural edges of Guilford County just to really get people engaged and engaging in positive health behaviors and educating them about chronic disease. So for my group, we were particularly interested in kind of getting to the people who don't come out because in the years that we've been doing this, it doesn't matter where we are in Guilford County. If we're a repeat, the same people come out over and over. You might find that they bring a few more friends or relatives. So I decided to take a different approach and bring the message to the people. So we partnered with the libraries in Guilford County. We also partnered with Resources for Seniors of Guilford to go out on with them to their rural outreach community. We also partnered with the Greensboro Housing Authority so that we can kind of capture, lower income folks who are kind of in our age catchment. So we were hoping to get people who were at least 40 and above, but we ended up getting some other folks because we were at health fairs where all demographics were represented. So we did have a few 18 and 20 and 30-year olds complete the survey. So that
Yeah, that's
answers
where I
some of
was
your questions.
that
Yes.
was my leading question because when I saw the findings, it
Mm-hmm.
was I think I made note like the participants went from 20 to 70 and you
Yes.
had some findings and I was like, "Oh, that's a cool survey? Because you had quite an age range, and your findings are there's a little spoiler alert. The findings are age distributed too. I'm random with my words, but that was fascinating to me that you had a younger group participate, like a lot.
Yes. And it's really because of our approach, because we kind of took the message to the people instead of inviting the usual group of folks that we would. So if we were at a huge event, we even went to powwows. So Guilford County has there's a unity conference, a powwow that they have for in Guilford County every year. So we kind of went. We went to two powwows in Burlington as well as in
I don't
Greensboro
know.
proper.
I don't know what those are, and it sounds like something politically incorrect unless it actually involves indigenous
No,
folks. What
it
is
actually does involve indigenous folks. So
Okay,
there are
good.
several
I had a feeling it
indigenous
probably
groups.
did. I was like, wait, what is
Yeah,
that?
so there are several indigenous groups throughout the well, I would say central North Carolina, the Piedmonts, I mean, not only do they have representation in our state legislature, but they also have distinct groups and they put on annual powwows. And I discovered through this experience that there's this group, I'm going to tell you, I'm not, because I don't want to butcher the name, the Okinichi Band of the Saponi group. They have a designated protected land in the outskirts of Burlington, which I didn't know, ancestral land that they have an annual powwow in. And then there's also another one that the coalition, the Native American Coalition in Guilford County puts on one every year. So we go to where the people are. So that's why we have such a huge age distribution. So when we went to the housing authority, we, captured our targeted demographic group, or well, our primary, I should say, because everyone should have education about brain health and Alzheimer's disease risks, because as we're learning, people who are caregivers can be of any age and increasingly so. I was a caregiver for Alzheimer's disease patient earlier because, as I mentioned, I lost my mother earlier on to breast cancer. So that kind of put me in the seat a little bit earlier than others. So that's why we have such a huge demographic. So that was our approach. We really wanted to capture individuals who are lower income, who are less educated, in addition to the usual suspects with our
Mhm.
survey.
And also, given you're a professor and you work at a university and you're surrounded with students, many of whom are younger, you have a full cadre of younger folk. Did you include any of your college students that you, or was this
We
community based where you were not like, hey, class, you have to fill this out too?
No, we did not do class. They had to fill this out too. We still have rules about that, but we did capture some students because the university, the student health center, does put on a wellness fair for students
Got
once a year. So we did pop in there once to collect data just out of curiosity, but the remainder of the data collection was done in and around the community.
So you did the who was participated. You did the how, which is you did a survey. I don't know, you talk generally and but if you can mention what the survey was, because I took it a little bit.
It's
I saw
fun.
it. How many questions, and you can throw out and I know you gave the brackets of the questions, but if you want to remind
Mhm.
folks, so people filled out a survey, how long did it take
Yes,
them and what was it like kind of the questions?
it was quick. So I'm trying this new thing. And if it works, I think I might turn it into some sort of a brain health intervention. So I made it like a game. I did a brain health trivia. So people, were able to kind of swing by and scan the QR code. And, for those who didn't want to use the QR code, we had students kind of around with their tablets. And it was just this fun, 17 item questions, just true or false. Are these statements true? And I threw some examples out there, will X walking 30 minutes a day, improve your brain health? True or false? Is delirium always an indicator of, cognitive impairment or Alzheimer's disease? True or false? So all people had to do was say true or false. And it was this fun thing because if they did it through their QR code or through the tablet, then they got their little score. So since we were doing it in the community, some folks who were out at fairs and things like that or at powwows, they had fun competing against each other and comparing scores about how many they got right. So
Got
people
it.
were kind of really engaged and it didn't feel very much like research. It felt kind of like this fun thing. And then, and based on what they got right or wrong, we would distribute, appropriate, brain health information or information about chronic disease or Alzheimer's disease. So it was kind of like a learning and collecting data.
Well, and
Uh,
that's a good lead into the next question, which is sort of what did you find out from how people answered it? So the findings in a research way, and then you started here's I like to do two questions at once, and then you started to answer the and what happened to the participants, the kind of and then what based on their answers. So however you want to, should just ask one question at a
Wait,
time. I
I
know I
think you
should
lost me. The last part. So the
I'll do
then
the
what?
let's do the last part first, which is they answered the questions,
Mhm,
because then we'll talk about the research findings in a second, but let's still stay. So they fill out the tablet, and
mhm.
then based on how they answered, what did everyone get the same education or
They
based on
got the
how they
score. No, I mean, well, they had a choice. I mean, if they answered something, because it depends also how engaged they were, because again, depending on the setting, sometimes
yeah.
we had a smaller group. If we were doing a lunch and learn, let's say, for example, at the, Greensboro Housing Authority or the library, we can directly answer. And if we were at a health fair, sometimes things got a little bit dicey. So we had the full gamut of information when we tabled at these various events. So we had information about brain health, Alzheimer's disease diagnosis, and we have about chronic disease. And then we also had, referrals of where they can go get brain health. So once they kind of got their little score, if they were in a health fair setting, then and a lot of they had the opportunity to ask questions, and we gave them information about things that they got wrong if we were in a position to or had enough bandwidth, and they were allowed to pick up all the information. So most people kind of picked up information about things that they got wrong or the end that they were generally interested in or that they thought that would be helpful to their family members. In our lunch and learn settings, we were able to do a deeper dive. So our lunch and learn settings, we kind of did these brain health series. So part one, the first year was just kind of like dementia basics. So we talked about, how does Alzheimer's disease get diagnosed? What are some of the risk factors? What dementia is and isn't. And
Hmm.
so they completed a survey before. So then we went into the deeper dive about those things. And then we
Hmm.
talked a lot about chronic disease, what I like to call the big three, right? Heart disease, diabetes, and hypertension, right? Especially in communities of color. So we talked more extensively about the big three. So people in the lunch and learn settings were getting a little bit of a deeper dive into dementia and chronic disease risk factors, and people in health settings were getting more
Hmm.
kind of public health information.
Okay, so and this will be interesting, and especially since when I look at the folks on the call, a number of us do community education. And so what's interesting is this is both a mix of a community outreach and a community education tool. You asked a bunch of
Mm-hmm.
questions to then trigger a discussion or introduction of, hey, here's a bunch of resource materials. So that's interesting for those of us who do community-based education. But this was a research study, and so why don't you share the findings? And that's where I'd mix the two questions up. And so what did you hear back, or what are the findings as you started to combine the information?
So we found some very interesting things, a few that I suspected, but a couple of surprises. And you and I had a little cheat conversation about that. So three of the biggest surprising ones. So the overall results is about of people what they got correct and what they got incorrect. So majority of the questions were answered correctly, especially those around health behaviors. So what I recognize is that, all the wonderful public health messaging that this and the work that the CDC has done over the years is really getting to the people. So people were very aware that, exercise and nutrition are important factors in preserving brain health and overall, aging well and mobility. Whether or not they were engaging, they were at least knowledgeable about it. So that's a whole different one, right? Getting people to engage in behavior. But surprisingly, there were three areas that people got wrong, like 40% or more, and in one case, almost 50%. So one of our statements, age is the greatest risk factor for developing Alzheimer's disease. Almost 40% of our respondents incorrectly answered false. So those of us who are in this world might find that surprising because age is the greatest risk factor. I mean, you can be perfectly not have a lot of chronic disease burden, but still, living to be above a certain age is the greatest risk factor for developing, late onset or traditional onset Alzheimer's disease. And 40% of our respondents answered that incorrectly. 47% of our respondents answered incorrectly. They believe that getting lost in familiar places is actually common in old age, which it is not, as we all know. So that's a huge aging myth and kind of a red flag because when you think about it, that's one of the telltale signs of individuals, kind of being in that early stage. I mean, that's one of the reasons why I was able to convince my uncle that my grandmother was in the early stages of Alzheimer's because he and I had been talking about, I'm like, I'd moved to North Carolina, I left her in New York City, and he was the next of kin. And I was saying, I'm seeing these signs, please take her to get screened. And he was just so resistant. He was like, oh, she's getting old. And, she'd lived in New York City for over 50 years. She never drove a day in her life. And she was always up and down on the train. And she hopped on the train to Midtown one day and she could not get herself back. She spent almost half a day lost, and she had to call him to come and rescue her. And that was what triggered
Mhm.
the actual screening and confirmation of her Alzheimer's disease diagnosis. So even now, 47% of people still believe often that, it's a common in old age to be getting lost in familiar places.
And
And the last,
oh, I think I was gonna say, and then deciding whether I should let you say the third one. That one to me is really interesting because the first one, I'm not sure if I don't know how I would action orient it's an education thing about age being a risk factor. But the fact that 47% felt that it was common means that those folks are that there's a perception that there's not a problem, which means they're not getting assessed, and there's not an
exactly.
intervention. And so that to me is an action-oriented problem. I can't find the word for
Yes.
that, but that should be um to give me a better word for trigger, but that should be a sign that someone needs more assistance or support or exploration into it.
Absolutely.
And so the
Mm-hmm.
fact that so many people just say, "Oh, well, that's um, to the
Part
extent we
of
can
getting
generalize
old.
with the findings, yeah." And so then they don't see it as a concern. To me, that's a big one. So I just
It
wanted to sort
is.
of like hone in on that before you say the third one. Okay, and then the third big aha moment.
And the other big aha moment, diabetes is linked to Alzheimer's disease. So close to 41% incorrectly answered false.
And
So
that's
those
the
are the,
one I did offer because I saw the questions and Lindsay, don't think poorly of me and those of you who are more. And I was like, I'd like to say I would say, oh yeah, true, but I'm not sure if I would have caught that that was a risk factor. And so I have to self-disclose that when I saw that question, I'm like, I'm not sure if I would have. I know of other ones that were risk factors, but I just don't think I've thought about that and making the link about such a prevalent issue of diabetes and a prevalent of Alzheimer's and how they may be associated or linked. Um, or they not, maybe they are if it's a
they
risk factor.
are,
So
they
that was
are
an aha
linked.
moment for me. And so I'm self-disclosing. I think I would have gotten that one potentially wrong as well. And that is also concerning, right? Because it means that, right, if folks have diabetes, that their themselves and their family members should be is the concern that they should be extra aware of potential brain change and to not take that
Lightly,
lightly.
absolutely. Yes. And also becoming more hypervigilant about, adherence, right, to managing their diabetes. Because, yeah. Mhm.
So those are three big, and again, folks, if you want to jump in with questions, but I know we're
Yeah,
still
I want to ask
some
the
other,
audience before we jump into the rest of it. I just want
yeah.
to kind of get other people's reactions and just your experiences. I mean, have you found similar experience? Have you had similar experiences in communicating with people? And what are your thoughts on kind of like the three big ones that people tend to get wrong still?
Cassandra, hi, it's Karen.
Okay.
Karen Appert for anyone who doesn't know me. I really am intrigued with the three. I mean, I'm not completely surprised, but very intrigued, and I think I'm so glad you're on this because I know you're. I love that you dig in so much to things like that. And I would say that one of the, and you've probably heard this many times, but one of the things that was a big light bulb for me was I was at a talk one time by a researcher at Wake Forest who talked about the fact that some people are calling diabetes, they're calling Alzheimer's
Mhm.
type 3 diabetes. And I thought that was a really interesting way to
Yeah.
look at it. Is
Mhm.
there still, or is that, I haven't really looked at it, but is that still a thing that people are talking about?
Yes, very much so. See, that's perfect. I'm glad you said it.
Forgot
I didn't
about
have
that.
to say it.
Thank you.
That's actually what I was going to say next. I mean, it's such a driving factor right now, both for Alzheimer's disease and cardiovascular dementia, that, they are kind of calling it like this, this other, dementia, this Alzheimer's disease, like type 3 Alzheimer's disease, because it's such a huge driving factor. And there's such a high conversion rate between individuals who have chronic diabetes. And of course, your risk increases the longer that you've had it. So getting diagnosed with diabetes when you're 60 is very different than getting diagnosed with diabetes when you're 35 or 40. And if you're younger and you're taking your medication, you kind of take it for granted, but that cumulative effect is even stronger, as you get into later life, when you've had it longer. And some individuals have poorly managed or poorly controlled diabetes, and that only further compounds and exacerbates the risk and the onset. So there's a lot of people with poorly controlled diabetes and diabetes for an extended period of time, 10 or they also have earlier onset of cognitive impairment, which again, can easily convert to Alzheimer's disease and cardiovascular dementias and the like as well.
You know, excuse me. I'm constantly amazed at the number of people that don't realize that there are any factors that can, impact dementia. I mean, they just think
Mhm.
if you're going to get it, you're going to get it, and
Right.
they don't understand there are things that you can do on
Mhm.
that. So I'm interested, did your study find that there were a lot of people that just didn't have a clue that maybe they were, is there a way of just telling they were just guessing at answers? Or
Well,
probably not.
Good point.
yeah.
There's 50% chance of getting it right just from a guess. Huh.
Yeah, they had
Yeah.
50-50. So I'm sure there were a few that guessed. But I said we did have a large range of people of educational levels, some with some caregiving experience, some younger, some old. So we had a good mix of people. I would say, depending on the setting where I was, I can tell maybe some people were guessing. But I think in the settings where that was more of a concern, we were able to do more lunch and learn. So we're able to kind of get into the education piece and explain why and the how a little bit more. So those communities were able to kind of benefit from that.
Have you done any before and after research where, you looked at people before, maybe you did the educational sessions and then what their level of knowledge was after
No,
that?
but that's next.
Okay,
Because I
great.
think I want to expand the luncheon links. I was like, shucks, I should have had a backup search to get
That's
what's
true.
next. But
Just
I was so curious about
give it
this.
to the education and then give it again at the end.
Hmm.
Interesting.
Absolutely. Hmm.
Other findings that were surprising because I know I'll tee it up. I know there was some different findings based on age, on a number of things. Age, education were the two big ones, or were there other ones that you had kind of findings based on that you could start to categorize a little bit?
Yeah, the other findings were not surprising to me. So, only because tends to be kind of typical. We did find that there were some differences. So, the more educated you were, the more questions that you got right. Individuals who were in lower income brackets, including those who did not want to report income, tended to get things wrong. Of course, if you were older or getting closer, I'm sure you had, dementia on the brain, so you were more likely to be thinking about these things and be a little bit more aware. And you may also have been a caregiver. So individuals who were more educated, who were older, performed better. But there were, again, still some things that people got wrong. And if they had people who were lower income also got more wrong, were less knowledgeable about those factors. And we did expect that, which is one of the reasons why we kind of took the message to them.
Okay, then maybe, oh, I don't want to confuse things. I may have read it wrong then, and again,
Mhm.
it was the middle of the night. But I thought there was some finding about people over the age of 70. I thought they scored lower. But no, did I just read that wrong? Because I don't want to confuse the finding. There was something where
Okay,
actually I was surprised.
yeah, the categories. And again, this is how that's a confounder with people that were lower educated and had lower income as well. So when we chopped it up by age group and not just looked at it linearly, so linearly it just seemed like, if you were older or close to the age, you had better scores. When we looked at distinct age groups, then we did find there was kind of like this, what we call a bell curve. So if you were kind of, midlife and educated, then you had better scores. But if you were, 70 or over and had less, and you were less educated, then your scores were lower.
Okay,
So there's kind of a little bit of an interaction effect there
thank you.
that
Because
we're
I
going to
did
kind of
notice,
write that a little bit.
yeah,
Mhm.
because I noticed that and I was like, oh, and I don't know why, because I did think 070 you might have more experience with also, but um on the same end, maybe some of the behavioral public health messaging, as you said, maybe that would not have kicked in as much because it's happening more now. Okay, so thank you
Mhm.
for that. Any other because I want to move us into sort of the what next and other trends that this leads into, but any other findings that were noteworthy enough that it will drive action or were aha enough or whenever there's a research study there's always like discussion for further research, the things that you're like I want to pick up on this and move
Mhm.
forward. You've already touched on a few things, but
Yes, well, the top three, I mean, I think for me, I mean, those were the most significant, and I've been thinking about creative ways in which we can get the messaging out there. And we've talked about this as well with the North Carolina Coalition for was it dementia? I always forget all the acronyms, but so two follow-ups that I'm planning. One, I'm trying to work with a health communication specialist to think about what are some of the ways in which we can do a better job of kind of taking the public health campaign approach to getting the message out to the people to help dispel these myths? We're going to do a follow-up survey to this just to kind of find out where are people getting their health information from. I would say, especially people who are less educated, and come from lower income. So I really am not a fan of social media. I've been dragged kicking and screaming into the world of Instagram. I mean, Facebook was all I could handle, and I was reluctant even when it first started. But I mean, I've slowly been convinced, and it looks like because of these results, I may have to dip into the world or hire somebody to dip into the world of TikTok or things like that. But our immediate next steps is to do kind of a follow-up survey to find out where people are getting their health information from, especially again, those who have less education and are lower income, because maybe they may. What we found is that health literacy can be low in certain populations. So if you already have health literacy, where else should we be promoting this messaging so that we can kind of dispel these myths and help educate people about their risk factors. And then, based on those results, we'll kind of target where and how to do some more extensive public health messaging
Mhm,
to bring the message to the people, as I
mhm.
like to say.
Any other questions about this research study? Also, the basic things like is this going to be published or shared in a way, or if anyone is curious, especially those in our audience group who are educators themselves, who, you know,
Mhm.
did they have access to this survey to see if they may want to use it as educational tools when they're doing their own outreach, or what's
Yes, this
publishing?
will be published soon. That's going to be my project over spring break, which is in 2 weeks. So in 2 weeks, I'll be publishing the results of this. And as I said, we're going to expand it to collect more data because, again, we only did Central North Carolina, well, really the triad and the triangle. So we do want to collect more data to see if the findings hold, and hopefully expand it to some other southeastern states. So this is what we're going to be doing. And if anybody's interested in kind of using the survey for their own education piece and or would like to kind of collaborate to test it out, I'm happy to share it with you as
Mhm.
well. Mhm.
Thank you. And I know one of the things I have struggled with in my educational and facilitative aspects is the use of true false questions. And I've heard mixed things about it. So I want your both psychologist background, because there's a psychology behind it, and your research background and your education background. So basically all your backgrounds smushed together because you come with a lot, which is the fear that I had heard about using true false in an educational setting is that people can get confused and remember the question but not remember the answer. And so
Mhm.
there are certain things you want to be careful asking in a true false way because, or make all of the answers true. Like,
Mhm.
um, because otherwise you could be inadvertently, I'm trying to think of a good example. You could be continuing a myth like
Mhm.
all everyone gets Alzheimer's. Everyone
Mhm.
gets dementia, true or false. And so people might just remember the question, everyone gets it, but not remember the answer. And so you could, has
The
anyone else
correct
heard
answer.
that before as a concern about perpetuating myths and I remember just so I didn't know if that was ever when you start getting into the ethical issues about questions, both from a research as well as is this the best educational tool? Did that come up like, hey, we have to be careful that we don't perpetuate a myth?
Well, to be honest, I had not heard that. That did not come
Oh,
up, but I mean, it is something to be thinking about. I think that it only worked in our context because we embedded it into kind of like educational or
yes.
health promotion context. It wasn't just, massive true false questions and then we're done. So I think in our situation, it worked only because we had embedded them in this health promotional context. So I
Yeah.
think that kind of makes a big difference with what we were able to do, and without having to worry about, leaving them with, misinformation inadvertently.
Okay, great. I don't, for my next three in the
Mm-hmm.
morning rabbit hole research, I will look into in what context is it a risky thing to do? Um,
Mm-hmm.
but I like it because anything that's a game or it's interesting and people are like, oh, but I just and I think your questions were relatively they weren't there wasn't a moral hazard of it. There wasn't a danger of perpetuating something that could be. Um, there's a question, how can we reach you? I'm interested in looking at it and possibly collaborating. Betsy asked that.
Yeah, I'm gonna put my email in the chat. So just shoot me an email and I'll be happy to set up a time we
Thank
can chat.
you.
Mhm.
Absolutely, you're welcome.
So I want to just take a few more minutes and go bigger picture or contextualness. So you did
Mm-hmm.
this research as part of your CIDR work and your health and well-being lab. When you talked to the students recently, because I remember it was February 6th that you were doing it because I wasn't able to join, but you were talking about broader issues around health equity, health disparities, research, and policy and advocacy. And I just wanted your sense, and I know we're recording this. So I wanted to see if there's trends right now that you are seeing and navigating, and you and I have talked also about this in this time when certain words have taken on a political controversialness around health equity, DEI, looking at disparities. So I am
Mm-hmm.
curious when you spoke with your students and your colleagues about what are the trends you're seeing in research and practice, and how are you having to navigate these uncertain times? There, that was the question.
Ooh, okay. Navigating in certain times. Well, I would say, so, at A&T, we are under the auspices and all things under the General Assembly, which governs the entire UNC system. So, we are in a interesting place and position. being the school that we are, being well, when you go back to history, why we were founded, right? There are multiple interesting views on that, where we stand currently. I think on some levels, even though funding may be a challenge, I strongly believe, and I think students and colleagues feel the same, the work around improving equity, continue to addressing health disparities in communities will always continue. It doesn't matter if you're talking about rural health disparities, economic health disparities, other things that affect particular groups. I think people who are attracted to advocacy and policy work and health disparities or equity work are always driven to do these things with and without funding. A lot of this work historically started off with grassroots efforts with people wanting to solve problems in their community and support them. So before it became in vogue and there was funding attached to it, the work was getting done. I mean, unfortunately, not in such a large scale. I mean, funding plays a huge role in our ability to reach more people, and to conduct more effective work. But I think, I mean, all of you are involved with the, coalition on some level, and we all know that, our salaries don't reflect the amount of work and effort and passion that we have for the work that we do, whether it's caregiver advocacy or things like that. So I don't think that will change. We're just in a period where we are constrained by the language that we use and how we implement our work, but the work will continue on some scale.
Well, and I think thank you for that. And thank you, Mary. I know you have to go. Just one more moment about like framing and language. Is there a way, since a lot of the complexity goes around terms, and so
Mm-hmm.
terms start to they don't lose meaning, but people have such a strong reaction that I know for myself, I'm starting to, I mean, for years, different kinds of terms. How do different people experience things differently?
Mm-hmm.
Are there ways to frame questions that stay out of now? And I hate that we have to do this, but certain words have become so uh
Yes, some words.
complex, or yeah. What's
Yeah,
the
we
word I'm
have we
looking
have
for?
we have a very long of words that have been published. There has been some denial about that, but
Yeah, like the word woman.
yeah, it's like the word woman, exactly. I'm like, but you could say female gender instead of woman, right? Or biologically female at birth, right?
Yeah.
Instead of that one word, woman. You can say, so I mean, unfortunately, we do have to do some gymnastics, whip out our thesauruses, uh, so that we can find synonyms for words. But I mean, the work can be done. We can talk about, existing differences. We can frame them in the context of economics. I mean, we are a capitalist society. We're always interested in economics.
Got it.
And if we're clever, we know that economics always frequently follows people who, are marginalized or have what I call lower resource. That's another phrase that I've been using quite a lot. Lower resourced communities is my new favorite phrase.
This is helpful.
Um,
And
mhm,
sometimes I think it's a shame why we have to change language, but sometimes it's not a bad thing. I don't want to put too positive a spin on it, but it makes us start moving away to what do these words actually mean? And
mhm,
what are we trying to get across? And there has been a lot of pushback about those of us that you have 2 feet in the ivory tower. I kind of dance around it, but when things become too academic or too research terms, and then the general public is like, well, what does that really mean?
mhm.
What does equity mean? What does disparities mean? We know. So there is something about it's sad how we got here potentially, but making sure what is the language that we're using. And so there's I think the realities of navigating it, but also I think I was thinking about it the other night. There is something about finding more straightforward language to talk about it. Um,
Yeah.
what I hate is when people have to spend so much time figuring out how to say something that they can't do the actual work. And that
Yes, I mean,
and it
I agree with
distracts
you.
us from the big pictures when we're discussing. So I can talk out of both sides of my mouth about the language thing. We can take a lot of time and potentially waste time or distraction of focus by just talking about words as opposed to what are we doing and what's the work. But I was curious, and I don't want to ask you questions that would put you in any sort of a diplomatic uncomfortableness, but I am curious
Yes,
about
because I
your.
am still a state employee. I have to say all the right, I have to say all the sanctioned things and follow all the published
Yeah,
policies.
but I have been curious about the how it's impacting those that do this work on the everyday, where when you get together with students and they're entering this field of the combination of research and education and practice and advocacy work, what do you tell them? How do you help guide them right now with their interests?
And you and I have talked about this before, but unfortunately, I mean, there are a lot of faculty members whose work, especially applied work, has been directly affected by the change in policies, and they've lost funding, which has directly impacted students. Some students have lost scholarships, as well as funding for their research. Honestly, I just share with students what I shared with you, the realities of where we are. Um, if you're passionate about this work, there are multiple ways of being able to affect change. You may not always be compensated for that change, but I will say, at least in the context of the students who are part of the center, that are part of our student ambassadors who are being trained for this work, they all have their primary disciplines, future nurses, kinesiologists. So we've been talking a lot about what does that look like, perhaps in your practice? What does that look like? What does being a health equity advocate look like? When you're talking to patients or out in your community, because for me, I mean, even though I have both feet and I've retired, I'm a very practical person. So I always think about, the practical and applied implications of things. So we talk a lot about what that does that look like in practice. And what are some of the ways in which one might tweak their practices or their approaches to their clients or the community in their everyday work that will still help to affect positive change and close these gaps.
Mhm.
Mhm.
Well, thank you. All right, I will stop asking you questions, especially those that could. I don't want to get you in trouble, but you all, you see how fantastic Dr. Cassandra Germain is. You see,
Oh, you're too kind, Heather.
you're getting a little touch of her research, her work, and so ways we can partner together. Very excited about it, and that's one of our big things we can do through the coalition is help to link. And I loved that you were just connecting with Novant, and I love that you were connecting with other community partners, and people know that Cassandra's amazing to partner with. So you have both a research and a practice partner. Um, and then fun things when we're not like all recording. So however we can help together, it's really lovely. Thank you, thank you, thank you. Um,
Absolutely. You're so welcome. Thanks for having me.